Thanks, Ekaterina. Thanks for the invitation. It's nice to look around the room and see a lot of familiar faces and some new ones. Today I've been asked, I was quite pleased to hear that this conference is happening, and I was asked to give an update on some of the new therapies and some of the challenges that come with those therapies, and also really how this is a great opportunity, that we are really seeing a dramatic change in the hepatitis C landscape and what that affords us in terms of opportunities to really address this public health issue. So when I looked at the list of who's attending this conference, one of the things that struck me is that people really come from many diverse backgrounds, and so I will start by giving a little bit of background to the disease. So for some of you who are more experienced in this area, this is going to be a little bit of review, and for some of you it will be newer, and then I'll start to talk about some of the treatments and some of the other advances that have been going on. I'm not actually going to focus quite as much on immigrants, because Dr. Greenaway, who is really an expert on this, is going to be speaking after me, and she's going to be talking about that. So I will be talking more about hepatitis C in general, but linking it to new Canadians as an issue. So I'm going to start with some common misconceptions about hepatitis C, because I'm always amazed, even among people who work in this field, that some of these misconceptions persist. And for people that don't work in this field, these misconceptions are really almost universal. The first is that there's no effective treatment. So we're shocked at the number of not only people in the general public who don't know about hepatitis C therapy, but physicians. So if you go and ask primary care physicians around Toronto if there's effective therapy for hepatitis C, most of them will tell you no, and they will almost invariably tell you that it's not a curable infection. So this is fortunately slowly starting to change, but I'm going to show you that clearly this is a challenge. The other thing is that they will often tell you that if the liver blood tests are normal, that the person has inactive hepatitis C, and the final thing is that they will tell you is that hepatitis C is really only seen among people who inject drugs. And what I will say is that all of these things are untrue. So there is some truth to all of these statements, except for perhaps the first one, but that there really are not particularly true statements. So most of you know that hepatitis C is a major global public health problem. I just want to throw out some of these numbers because they are really fairly impressive. There's about 200 million people infected worldwide. The numbers vary, and you will see very wide-ranging estimates, as low as 85 million to as high as around 200 million. And why is there so much variability in that number? First of all, why does it matter if it's that specific? And second of all, why is there so much variability? Well, one of the things Leanne already touched on is that our surveillance data are not very good. So in Canada, which is a country with a lot of resources, our surveillance data are not very good. We don't really know how many people have hepatitis C infection in this country. And when you go around the world and you look at some of these high prevalence regions around the world, so if you look at the different colors, what you'll see is the colors, the countries in red are the countries with a very high prevalence of hepatitis C, and the ones in pink, somewhere between 2 and 5% of the population is estimated to be infected. But in most of these countries, how those data were collected is very poorly done, very variable and very poorly done. So the estimates in some countries, like you take a country like Nigeria, which has a population of about 100 million people, and the estimates in Nigeria range from about 1% to about 15% of the population. Just that country alone will change the whole global estimates of how much hepatitis C there is in the country. I do a fair bit of work in Ethiopia, and in Ethiopia there are 2 prevalence studies that estimate how much hepatitis C is there. One prevalence study says there's 1.1% of the population infected, and the other says there's 11% of the population infected. I don't think it's just a typo in the 1.1 and 11%. I think this truly is a challenge with collecting the data, because it's difficult to do. If we have trouble doing it in a country like Canada with all of our resources, you can imagine that this is even more difficult in many countries where resources are more limited. And as Leanne pointed out, the way that the data are collected, for example, if we do antibody screening versus actually looking at people who are virally infected, you will get different numbers. And the reason this is important is because the allocation of funding and the focus of diseases is largely based on numbers like these. So how many people are infected and how much burden of illness is caused both locally and globally. And I'll show you some of those data in a minute, but I just want to paint set the stage for the number of people infected. Now, most of you will know there's no vaccine for this infection, unlike hepatitis A and B, and at least in Canada, this is the leading indication for liver transplantation. Now, what you'll see is Canada here is shown in blue, which suggests that the prevalence of hepatitis C in our country is less than 1%. Now, I will say that probably, at least in the north, this should certainly be more of a green color, which would put it in the 1 to 2.5%. So, although today the focus is more on new Canadians, the oldest Canadians, the First Nations populations here, have a very high burden of this infection. That's to do with a number of things. Unfortunately, it is to do with a large degree of injection drug use among First Nations populations. But we do see that in the far north, hepatitis C, not only is there already established infection, but there is increasingly spread of infection around from one community to another. And we are trying to do some work with some of the communities in the north to try to stem the tide of this so that we can get a hold of what is to becoming a bit of a growing epidemic over time. So, why are there so many people infected with hepatitis C? Well, in wealthy countries, as Leanne mentioned, the predominant mode of infection is injection drug use, and we remind people that this may mean that they only used injected only once. So that can be, many patients will have experimented with drugs 20, 30 years ago and will now be paying the price for that. Tattoos, if done with poor quality needles, blood transfusions prior to screening the blood, cocaine use can transmit hepatitis C, although less so. Sexual transmission is actually relatively rare, with the exception of HIV-infected individuals, men who have sex with men. Mother-to-child transmission is fairly rare, as Leanne mentioned, and although it's pretty uncommon for the transmission to occur here through medical exposures, it still happens. We do have outbreaks every year, usually fairly contained ones, of spread through people being exposed to contaminated medical equipment. It's quite different in the rest of the world. So in low and middle income countries, medical transmission is by far and away the largest risk factor, and that actually is globally the #1 way that hepatitis C is transmitted between individuals. And so, of course, Canada as a country of immigrants, what I didn't list in that list of wealthy countries is, of course, being born in a country where hepatitis C is endemic. And this is a challenge because I can tell you, for individuals that come from countries where hepatitis C is more common, they may or may not know about it, and they don't always like hearing that they were infected in their country of origin through going to see a doctor, getting childhood vaccinations. But when you look at it, that is the strongest risk factor for acquiring hepatitis C in countries with developing medical systems. So if we look at the global burden, just showing this another way, I apologize for the Mac to PC challenge here, but this is looking at the number of people infected and listing the countries what I want to show here that's different than that first map that I showed is the total number of people infected versus the prevalence within a given country. And so what you see is, even though China has a relatively low prevalence, so it means that the number of people per population is low, the total number of infected people is actually highest in China. It's simply because they have the largest population in the world. But that means that, at least using these estimates, up to 30 million people are infected in China out of the 1.5 billion people in the country. And then if you take 2 steps down, you'll see that Egypt has a very high prevalence. So even though this is not a huge country, the prevalence in Egypt is extremely high. Many of you know that this was somewhat of a public health disaster where the government, in good faith, was trying to eradicate another infection called schistosomiasis and didn't have enough needles to deliver the medication, and unfortunately actually spread hepatitis C through the Nile Basin in the 50s, 60s, and even into the 70s, leading to an extremely high prevalence. It's estimated that somewhere between 15 and 20% of the population is infected, and if you look at the population over the age of 50, in some estimates it goes as high as 40% of the population being infected, which is why Egypt, which is a relatively small country, shows up as having the 3rd largest total number of people infected globally. But so what you see here is that the highest prevalence is in Egypt, but the largest absolute numbers are actually in Asia. When you look at China and India combined, they combine for almost 50 million total numbers of people infected. And what's very clear here, and is true with many bloodborne infections, is that the burden of illness is much greater in low and middle income countries than it is in wealthier nations. But I don't want to only focus on it being an issue of poorer countries. This is also a major public health issue in Canada. And these were data that were collected by Jeff Kwong and colleagues here in Toronto looking at Ontario. And what they looked at is they took 25 infectious diseases, and they said, of these 25 infectious diseases, which ones cause the greatest burden of illness? And they looked at a pretty robust thing. They looked at the number of years of life lost, and they also looked at the number of years of productive life lost. And I think even to those of us that work in this field, it was a bit of a surprise when the thing that came out on the top of this list was actually a hepatitis C virus infection. And so just to put that in context, hepatitis B comes out as fourth, but some big name infections like HIV actually comes out sixth on this list. And further down the list, you'll see things like influenza, which gets a lot of headlines. You'll see things like C. diff infection, which you also hear about outbreaks. Not to minimize the importance of those infections, but this just highlights that hepatitis C, which doesn't tend to get as much airtime and as much coverage in the press, actually leads all infections in Ontario and likely in the rest of the country in terms of its actual burden of health. So what happens when you get hepatitis C? Why does it cause disease? And why is it perhaps a little bit surprising that it tops that list? Well, this is the diagram that's typically shown, that you go from a nice healthy looking liver like you find in the grocery store, and if you have chronic infection for many years, that can progress to a scarred liver that you see in the middle, representing cirrhosis of the liver. And then once people have cirrhosis, that's when they're at risk of developing complications, particularly liver cancer. And this happens over many decades of infection. So this is not an acute illness that someone gets sick and dies. And part of the reason for it not grabbing people's attention is that this is a very, very slow illness to progress over time. But the other thing I want to point out here are the numbers. So what you'll usually see referred to is that about 20% of people will develop cirrhosis over their lifetime. And so the implication of that is that maybe 80% of people don't have any consequences of their disease. And this becomes a very important point, because if 80% of people don't have any consequences of their disease, do we really need to treat them all? And as we're going to discuss a little bit later, the treatments, although effective, are very expensive, so perhaps we don't need to give everybody treatment if only 20% are going to develop complications. But here's where I want to really point out that this is clearly a misconception, because what's the trouble with this is that the fine print is missing. So this 20% number is 20% at 20 years of infection. It's not 20% lifetime. And the challenge is that many of the people with this infection have had it for a very long time. So if you start to look at the risk at 30 years of infection, the rate of cirrhosis goes to above 40%, and it's very possible that the lifetime risk tops 60% for the risk of developing cirrhosis. And why is that true? Well, many people contract this infection in the immigrant population as children through medical exposures, or as young, maybe as young adults. And if they're contracting it locally, it's often through experimentation with injection drug use, which again typically happens in teens and 20s. So someone can certainly have this infection for 20, 30, 40, even 50 years, and it's only then that they start to develop the complications. And I can tell you my clinic is full of people in their 50s, 60s, and 70s who are now presenting with cirrhosis with an infection that they've carried for decades. And that's why these numbers, it's really important for us, in my opinion, to get the word out that this doesn't mean that 80% of people do not develop complications, because this 20% cirrhosis number is really used all the time. And the other challenge for our patients is that this infection really does catch you by surprise. I always say to my patients that the best thing about liver disease is it has no symptoms, and the worst thing about liver disease is it has no symptoms. So it is a little bit like walking backwards towards the edge of a cliff, and you really don't see what's coming. But so patients, even when they have cirrhosis, can feel entirely well, perfectly well. And it's only when they start to develop the signs of a failing liver that they become symptomatic. symptomatic. So for the patients, this often isn't on their radar screen because they feel well. This is what we're trying to prevent, all of the complications of end-stage liver disease, from retaining fluid to having internal bleeding, hepatic coma, jaundice, or liver cancer. But the reality, these are all the end-stage complications of the disease, and if we wait until people present with these complications, at that point it's much too late to do anything about it. Now, this just gives you some more local data comparing, again, this is in some ways really more the headline-grabbing data that hepatitis C, not to say it's not more important than HIV, but because of the remarkable successes of controlling HIV and the progression to AIDS and deaths related to that, hepatitis C has actually surpassed HIV as a cause of death in the United States. The data are likely true in Canada, although we haven't collected them in the same way, other than what I showed you before. Now, the challenge for us is that the problem with hepatitis C in the coming years is that we are just reaching the beginning of the problem. So as I mentioned, this is a disease that progresses over decades, and what we see is that the number of people infected in Canada may actually be going down, the total number of people, but what is about to increase and increase at a very rapid rate is the number of people developing complications from the disease. And that's because many of the people who acquired this infection either through blood transfusions or injection drug use in the 60s and 70s are now developing cirrhosis and its complications. And in addition, that's true for people that have come to the country harboring the infection. And so this just looks at estimates for the United States, where it was estimated that in 2010 about a quarter of people with hepatitis C had cirrhosis, and that by 2020 that will be upwards of 37%. And likely the data are very similar for Canada. If you look at our rates of liver cancer, it's anticipated that rates of liver cancer, which is largely driven by hepatitis C in Canada, will be rising until 2027 or possibly longer unless we do something about it. So the good news is that there is treatment available for hepatitis C, and some of you may be aware that this infection has been treated for a long time with a medication called interferon. Interferon is a miserable medication to take. It's an injectable medicine that causes many side effects, which I'll mention in a moment, but when it was initially used back in the 90s, you can see that only about 6% of people achieved cure, but by 2002 there was some progress made, and over half of the people that were treated were able to be cured with this infection. And I'll talk about what I mean by cure in a second. So I'm now going to move on to the point about treatment and really want to hammer home the point that this is a curable infection. And that's not that may sound like, well, we have lots of curable infections. This is really an amazing achievement. This is the first chronic viral infection to be cured. So no one has ever been cured of HIV. No one has ever been cured of hepatitis B. We can now cure the majority of people with hepatitis C. So that really is a monumental medical achievement, and it has major implications for preventing complications for all of our patients with this, living with this infection. So I just first want to prove to you that this really is a cure, because what you'll see is that if you read papers about this or you read the newspaper, they'll often say they have a sort of cure or they talk about a potential cure. And the reason people are uncomfortable using the word cure is because the doctors have insisted on using this term sustained virological response, or SVR. And what does that mean? It means exactly what it says, is that the virus is suppressed and it's suppressed long term. But I want to show you that this really is long term. So this is taking people who achieved this endpoint, sustained virological response. You can see over 1,000 patients, and you can see following them for many years that the rate of relapse was extremely low, less than 1%. So when someone has undetectable virus in their blood 6 months after the end of treatment, and now pushing it up to even 3 months after the end of treatment, we can be certain that the virus is not coming back with over 99% certainty. So that's why we say it's cured. And we really should say that SVR is a cure. The reason we haven't, I'll come to in a moment, but you'll see, and I just want to really stress the point that this term SVR, which I'm going to use over and over again, really does mean virological cure. So why is it a cure? Well, we know that when you cure someone of infection, they shouldn't have any complications of it. And if you look at these survival curves for people who started with their treatment with mild liver disease at baseline, you can see that if you compare them to the general population here on the left, you can see that they actually have the same survival if they're cured of their infection. So they really do extremely well. And you can see on the right curve, at the very bottom, their risk of having liver failure or liver cancer is extremely low over time. So basically, if you can get rid of the virus before they have advanced liver disease, you really eliminate the risk of any complications. But perhaps even more importantly is even if you can cure someone after they've developed advanced liver damage, so someone that already has cirrhosis, what you see here is if you can get rid of the virus and achieve this endpoint of SVR, you can see this is showing the probability of someone developing liver-related complications, and you see, or liver-related mortality, and you can see it's extremely low after someone achieves SVR, whereas those patients who do not achieve SVR, so people who don't respond to the therapy, you can see that they go on to continue to have a very high risk of dying over time. And more importantly than that, because this was looking at what is the chance of dying of liver-related disease, but it's not so helpful if we cure our patients and prevent them from dying of a liver-related complication and then they die of something else very shortly after. So this study, which was published a few years ago, we worked on it, and it was a collaboration between our group in Canada and some European centers, really showed that this endpoint SVR is not a surrogate endpoint. This really is a very important endpoint, because what this study was the first to show is that if you cured people, you reduced their overall mortality, so death from all causes, not just liver disease. And the reason for that is that hepatitis C is not only associated with progressive liver disease, it increases the risk of many other illnesses, particularly diabetes, and there's the associated heart disease that comes along with that. Hepatitis C increases the risk of certain kinds of lymphoma or blood cancer. If you can cure the infection, you reduce the risk of not only dying of liver disease, but of dying of these other complications as well. Now, one minor point but worth mentioning is that people who have cirrhosis before they're cured still have a risk of liver cancer, and that's why you see that the patients who have achieved SVR have a lower risk of liver cancer here, but they still have a risk of liver cancer over time, which means that they still need to be followed. And it's because of that that we don't call this a cure. It's because people with cirrhosis have a virological cure, the virus is gone, but they still have advanced liver damage and are still at some risk of liver disease, of liver cancer, and so their liver isn't really cured. And that's why there's been this reluctance in the medical community, initially because we were worried the virus was hiding out somewhere and was going to come back later, and secondly because of this issue that although the viral infection is cured, the liver damage persists in people who are only treated after they have advanced liver damage. But I do want to really stress this point, because you will see it in all of the literature you may come across about hepatitis C, that for people who don't have cirrhosis at baseline, SVR really is a cure. They have a normal life expectancy, and there really is no issue with liver disease following that. In people with cirrhosis, it really eliminates the risk of liver failure. It greatly reduces the risk of liver cancer, and it improves both their liver-related and overall survival, and it actually comes close to normalizing their life expectancy. So this is a major achievement, and it shouldn't be minimized, the importance of this term. And I would just say for the non-medical people, sometimes it's confusing that there's this insistence to not use the word cure, but when you read about this is a curable infection. I really want to stress that point. So I titled this slide the good news, but of course the bad news is that this slide is 10 years old, or more than 10 years old now, with going back to those final numbers in 2002. So the problem with the treatment that we had before was that interferon has a host of side effects. Interferon is what your body normally produces to fight virus infections. So when you have the flu, part of the reason you feel lousy is because your body's pumping out interferon. So you can imagine when we inject you with interferon, you feel a bit like you've got the flu. And so imagine having flu-like symptoms and all of the things that go along with that, fatigue. It can make people depressed and cause other psychiatric problems. It also suppresses the bone marrow, so it can have problems with lots of blood counts, as well as all of this other list of side effects that happen. And people had to take this treatment for up to a year with weekly injections and daily pills. This was very, very difficult, and so you can imagine that many patients didn't want to do it, especially when the efficacy rates that I just showed you were only about 50%. Fortunately, unlike hepatitis B, for example, hepatitis C does give us a lot of opportunities to target the virus and directly kill the virus. So interferon really stimulates your immune system to control the virus. We now have the opportunity to target specific aspects of the viral life cycle and interfere with them so that the virus can't replicate and can be eradicated. And so we can block entry, we can block viral enzymes, one called the protease, one called the polymerase, and one called the non-structural 5A protein. And the details don't matter except to say that targeting these, like you've probably heard of HIV cocktails, where you have medications that target different aspects of the HIV life cycle, these medications target different aspects of the hepatitis C life cycle, and when combined, can very effectively limit viral replication. But why has it taken so long? Well, so the first thing is that hepatitis C is a remarkably diverse virus. And this, just to show you, this is putting them, hepatitis C and HIV on the same scale. And the size of that scale, this is looking at the sequence of the virus, comparing different sequences from different individuals. And what you can see is that all of the variability in HIV fits into one genotype. It's about the same size as just genotype 1 of hepatitis C. So what this tells you is that this is an incredibly diverse virus. And what does that mean? Well, it has implications for developing a vaccine. It's very difficult to develop a vaccine because the virus is constantly changing and mutating. It can escape from your immune system. And the second thing is when you develop drugs, it means that the virus can also develop mutations to make those drugs not effective, so that the drugs, so the virus becomes resistant to the drugs. And this is an important challenge that makes hepatitis C more challenging than some other infections because of this incredible diversity. The other thing that's been a challenge is that as drugs have been developed, it's been apparent that some of them have led to toxicity. And because in general, this is an infection that causes morbidity and mortality slowly over many years, there's been a lot of resistance to fast-tracking drugs. So with HIV, when people were dropping like flies in the 90s, there was a great concern, a concerted effort to push the agenda forward and say, we'll take a bit of a risk because people are dying quickly. We really need these medications fast. And in hepatitis C, there's been a little bit less urgency, or at least that's been the argument that's been made, because the infection is rarely an emergency to treat someone. The infection is going to cause problems over years. But of course, the people that have already progressed to that advanced stage of liver disease, they may not be able to wait for this slow process of drug approval, and it has taken quite some time. But I would say that the real reason for this is unfortunately, if this is the HIV lobby, the hepatitis C lobby has looked a little bit more like this. And I say this a little bit tongue-in-cheek, and it's not to say that the hepatitis C lobby is lazy. I'll show you what the consequence of this. This is not just this isn't just theory. This is looking at the total number of infections shown on the right and of undiagnosed infections, comparing hepatitis HIV in yellow, hepatitis B in purple, and hepatitis C in blue. And so what you can see, these are American data, but you can see that hepatitis C has a lot more infections, a lot more undiagnosed infections, and yet the amount that's spent on care, prevention, and research in the National Institutes of Health budget in the United States is really almost exclusively spent on HIV. You can see that hepatitis C and hepatitis B barely register on the radar screen. And why is that the reality? Well, the reality is that hepatitis C really is a disease of the marginalized. So it's if you look at the prevalence among people who in these high-risk groups, that what you see is that among people who inject drugs for greater than 10 years, the probability they'll be infected with hepatitis C is upwards of 90%. And for people that have used injection drugs for shorter times, it may be as high as 50%. But if you look at some of the other groups there, persons with, who are in a homeless situation, people who are incarcerated, people with severe mental illness, even just being hospitalized, and in the United States being of an African American ethnicity, you can see that these groups dwarf the general population shown just down at the bottom at 2%. And what's not shown here is what about the immigrant population in the United States. There's been a lot of discussion about looking at the immigrant population and really no firm action on whether or not they should specifically target the immigrant population to the United States as a higher risk group. But what you can see is that the consequence of these groups who generally don't have a strong political voice is that this leads to a lack of funding, a lack of research, and a lack of progress in the area. But fortunately, there has been progress. There has been development of a number of different drugs, and I'm just going to show you what this has looked like in a schematic. If you start out with how effective a drug is versus how safe and tolerable it is. Interferon was really low at the list. It wasn't very effective and wasn't very well tolerated. And our first generation of these so-called direct antivirals, these drugs that directly target the virus, actually they were more effective, but they still had to be taken with interferon. So the tolerability actually was a little bit worse. And then as we've moved forward, we've had drugs that are a bit better tolerated, but it's really only when we start to get rid of interferon that we start to get highly effective regimens that are very well tolerated, and it's very likely, and we're very close to this, of having what I would call sort of our goal here of having a one pill once a day with very few or no side effects with a close to 100% cure rate. And this is the drug that I sometimes call perfectovir, and this drug is now getting very close to being available. So I just want to show you some of the progress. It's not very often that a single disease gets this much attention in the New England Journal of Medicine. There have been 19 trials published in the New England Journal since 2012, which is really, I think, probably rivals cardiology as the only thing that might be more common in that period of time. And I just want to show you these really high success rates. I'm not going to spend much time on the details of the drugs. This is a combination of a few different drugs taken together, a protease inhibitor, NS5A inhibitor, and a polymerase inhibitor combined. So two of these drugs are combined into one tablet, and then the other tablet is taken separately, combined with ribavirin, and just taken for 3 months. So this is a total of 3 pills in the morning and 1 pill at night, taken for 3 months. And you can see that the cure rates here are upwards of 95% for either people who have never been treated before or people who have failed prior therapy. So that's a dramatic improvement over the 40 to 50% rates that I was showing you before. And in addition, there is actually a single pill combination using a different regimen. This is also a polymerase inhibitor with an NS5A inhibitor. These are combined, 2 medicines combined into 1 tablet and taken for between 12 and 24 weeks, and actually over here on the left you can see taken for as little as 8 weeks, and people achieving cure rates upwards of 90% in every group, and this is very well tolerated with really no issues of resistance. So I think this idea that we will have this perfect combination, and these drugs are not perfect, there are some challenges with them, but we are getting close to a situation where we will have drugs that don't require interferon or ribavirin, have cure rates above 95% with few or no side effects, few or no drug interactions, and resistance will be a little minimal problem, and with treatment for as short as potentially 6 weeks. So in theory, if we have these great therapies, why can't we get rid of hepatitis C? And actually, HCV eradication has started to be raised in the consciousness as something that we could potentially achieve. But I want to make the case that it's going to take a lot more than good drugs to do that. So disease eradication is possible. It's been done twice in human history, once with smallpox and once with rinderpest, which is a cow infection. But this took a huge, enormous effort with a highly effective and successful vaccine. It's never been done with just treating an infection into eradication. So what do you need to do to eradicate infectious disease? Well, first, it can't be spread in animals. It must be, because otherwise we'll reinfect the human population. You need to be able to treat and cure all those who are infected, and you have to, most importantly, prevent all new, well, at least all new chronic infections. So this sounds simple enough. So if we go through these, well, there is fortunately no animal reservoir. Chimpanzees can be infected with hepatitis C, but unless we infect them, they don't naturally harbor this infection. So there's no risk of it coming back from the animal kingdom to humans. So the second thing, what about treating and curing all those infected? Well, this should be easy if we've got these perfect drugs. So in theory, once we have these perfect drugs, we should see lineups coming to my liver clinic to get treated. But so why doesn't this happen? Well, the first thing is, for people that have already taken interferon, actually that is what's happening. They're lining up and they're asking to be seen and get access to these new therapies because they were motivated enough to take a very difficult, relatively ineffective treatment. You can imagine that they're much more excited to take a highly effective, well-tolerated treatment. But for everybody else, they're not really that anxious to be treated. So if you've never had interferon, you actually don't realize how much better having a treatment without interferon is. And if you've never taken medication for 12 months, 3 months actually sounds like a really long time. Think of the last time you had to take antibiotics for a week. It was difficult to remember to take it at the end when you started to feel better. And so adherence becomes a major issue, is that people have to remember to take these pills every single day for those 3 months. And missing treatment, if you remember what I said about that virus diversity, if they miss treatment, the virus can become resistant to these treatments and lead to treatment failure. So adherence is absolutely critical. And the second thing is, and probably the biggest issue, is that if you don't know you have hepatitis C and you feel fine, even if you know you have it, you don't really seek treatment at all, because this isn't something that is high on your problem list if you don't know you have it or you feel perfectly well with it. So even when we have these perfect therapies, many people who are infected with this infection will not want to access treatment. And underdiagnosis and undertreatment really are major issues. So what this plot shows is at the bottom, on the bottom axis is the diagnosis rate, and on the y-axis is the treatment rate. And so I want to show you a few different groups of countries. So you see the best countries in the world have a diagnosis rate, they're able to diagnose somewhere between 60 and 80% of the people infected in their countries with hepatitis C. And you can see in the highest treatment rate in the world, France, they look like they're really high up on that graph. Look over at what that number is. It's 5%. So they're actually treating 5% per year of infected people. So even with the best country in the world with a very active national action plan to address hepatitis C and increase treatment uptake, they're still only treating 5% per year of the infected population. Now, if you look at Canada, in theory, supposedly we've diagnosed 78% of infected, or sorry, 79% of infected people in the country. I will challenge that number greatly. I think the data are not based on very good data. I don't blame the people that came up with the estimates. They used the data they had. It's from the Public Health Agency of Canada, but unfortunately they didn't have very good data on which to base those estimates. And as a consequence, it's probably that our diagnosis rate is under 50%. Some estimates, the most recent data from Statistics Canada actually suggests it's potentially as low as 30%. I think that's probably a little bit low, but it probably is in the 40 to 50% range, meaning that most of the people with this infection don't even know they have it. So it's not really that surprising that our treatment rates are in the range of 1% per year. So we're only treating 1% per year. And then if you look in globally, the biggest problem is that in the countries with the biggest bubbles on this graph, which tells you the burden of infection, the number of people that they have in their country with the infection, you can see Egypt has a huge bubble, 10% diagnosis rate and a less than 1% treatment rate. So most people are not diagnosed, and almost nobody, even if they are diagnosed, is getting treated. So why are the treatment rates so low? Well, this is looking at American data. I suspect it's similar in Canada. If you start out with the estimated 3.5 million people infected in the US, first of all, only about 50% are ever diagnosed, and then of those 50%, there's a little bit of a drop-off to accessing outpatient care, but you can see that of the 50% that are initially diagnosed, only half of those, 27%, will ever have confirmation that they actually have chronic hepatitis C infection, so that the virus level is checked. And if you look at the number that are treated, down to 16%, and the number cured under 10%. So you can see that this cascade of care really is a major problem, is that we're seeing major drop-offs, but that first drop-off is just in getting people diagnosed in the first place. Now this should improve as we move to interferon-free therapy, but you can see that there's a lot more that we need to do. And this just puts this into context. So on the right, you can see that this is looking at the cure rate in an individual. And what I've shown you is these new drugs are fantastic. And so you can see that by 2000, by now, even really, we're achieving cure rates upwards of 90%. But if we continue to treat the same number of people that we're treating, if you only treat 1% of the population, that means that if you have a 90% success rate, you've cured 0.9% of the population, right? So this is looking at the effect of those therapies at the population level if we continue to treat the number of people we are currently treating. So this really shows you that treatment uptake is actually as or more important than the cure rate itself for a particular regimen. So why are the treatments so low? Treatment rates so low? Patients are largely unaware of their infection, and at least in the early years of the infection usually feel perfectly well. They don't really want treatment because it's relatively difficult even when we get to these very well-tolerated treatments. Doctors, as I mentioned at the beginning, have very poor awareness. Some, in the order of 50% of family doctors in Toronto are unaware that hepatitis C is a curable infection. These are data from last year. This is a Canadian Liver Foundation survey. So this is not just among the general population, this is also among the medical community. And we have very few people who treat this infection. There are relatively few hepatologists, liver doctors like me. Some gastroenterologists treat this and some infectious disease doctors treat this, but not enough of them. So hopefully primary care doctors will start to take up treatment like they have done in HIV, but that hasn't happened yet. People should be screened for this infection, certainly anyone with abnormal liver tests, and I would make the case that people who are born in high endemic countries, particularly Egypt and Pakistan, which have very high prevalence and large communities in Toronto, and you can see some other hotspots here as well as people with risk factors. But the challenge has been, this sounds good, but this is actually very hard to implement. So the current screening recommendations from the Public Health Agency of Canada are to screen people based on their risk factor profile. But I want you just to imagine this and think about you operationalizing this. When you're sitting in front of a person in your office, you're a new family doctor, or you've been seeing this patient for years. The topic of did you use injection drugs 25 years ago when you were a teenager, when you're sitting there with your spouse and your children, is not necessarily something somebody wants to talk about. It's not necessarily something you want to talk about or have the time to talk about when you've got a busy waiting room and you realize that when you open that, there may be a lot of issues to explore. And for people who are not native-born Canadians, when you raise the issue that they may have been infected in their country through unsafe medical practices, that often makes it feels like you're attaching a stigma and an association about the quality of care in their country, and some people take very personal offense to that. So these are things that even if the doctor's aware and has good intentions, they may or may not recognize the risk factors, and they may or may not address the risk factors, and the individual may not be so forthcoming about some of these risk factors that may have happened many, many years ago. So the challenge is that risk factor-based screening really doesn't work very well. So the US has recommended that people be screened based on their age demographic because this is much easier to operationalize. It's much simpler if you walk into my office and I say, what year were you born? Okay, you qualify for hepatitis C screening. And the reason that they did this is that if they target baby boomers, those born between 45 and 65, they will actually identify 75% of the infected population in the United States. And in truth, the immigrant population will be included in that population because many of them will still be born between those birth years. The Canadian Liver Foundation has recommended that we extend that from 1945 to 75, and we just published a paper showing that this screening approach is actually cost-effective in Canada. Unfortunately, the Public Health Agency of Canada, I understand for some political reasons, has not advocated this yet. I hope that they will, and I'm hoping that there will be a screening recommendation forthcoming, but at least to date it has not occurred. So why is that? Well, at least partially because this is the payer's position. The concern is that if we diagnose a lot of people, we're going to have to pay for a lot of therapy. And this leads to treatment limitations to treatment access, certainly in Canada and largely through Western Europe. And why is that? Well, because you've probably heard some of the news about the costs of these therapies. These are just estimates for the cost of one of the drugs, Sofosbuvir, which is one of the very potent and effective therapies, and this came at the nice price tag of $1,000 per pill. And this drug was so expensive, they actually made the pill a little bigger than they needed to because they were afraid people would drop it down the sink. That's not a joke. But you can see that a course of therapy, of 12 weeks of therapy, costs close to $90,000. It is a little cheaper in Canada. The negotiated price in Canada, the list price is $55,000, so it's a good discount, but it's still very, very expensive. And then you'll see that down at the bottom, you see that Gilead, the company that makes this drug, has made this drug available at much cheaper prices for countries with lower incomes. But I just want to highlight what that graph actually looks like. So if you now take these countries that Iran, India, and Egypt probably highlighted the most, where they're getting about a 1% the price of the drug, but let's just put that into still the contrast that to the estimated production cost of this drug. And the argument that they need to recoup their research and development costs is just not a reasonable argument. They have more than recouped those costs already. This is the #1 selling drug in the history of drug development. They have made billions off this drug already and recouped their $11 billion investment to buy the drug, and this drug could be sold at a fraction of what it is currently being sold for, which would improve access. So the prices really are still a challenge, and that's something that we need to push governments and industry to change that. Because the standard model is that we basically maximize the price per pill, and this leads to a very high revenue in the US. And the argument is that that subsidizes the rest of the world, but you get relatively low treatment uptake everywhere else. Now, arguably, if you had a lower price per pill, you'd have reduced revenue in the US, but you'd potentially have greater global uptake and possibly even the same global revenue because of the higher burden of illness in so many other countries. And of course, you'd have much greater public health benefit. An alternative, now that the cure rates are so high, would be actually to encourage shorter therapy if you had a price per cure rather than a price per pill. But there is some concern that that would lead to people not being careful about getting reinfected or taking their medications, and then the possibility of adherence being an issue. I actually think that we should think a little bit more about spreading out the cost of this therapy. The challenge with hepatitis C therapy is that the cost is really front-loaded. So the treatment is only 3 months, and you have to spend those $84,000 or $55,000 in the 3 months of therapy. If you take HIV, the therapy is highly effective, but it's given for many, many years. So if you take someone who's HIV infected and over 10 years you might have spent $180,000 on their 10 years of treatment, the person still has HIV infection 10 years later, fortunately still living well with it. If you treat hepatitis C, you have to spend all of that money in a very short time. And when you think about our economies, we never do that. You don't buy a house and walk in with a bag of cash. You spread the cost over time. And I would encourage companies and governments and payers to think about amortizing the cost of hepatitis C treatment over a long time so that we pay back the cost of these therapies, which still should be lowered, but it would allow us to pay for more of it. And it's actually good for industry too, because it secures their market when they may be the market leader. So I would argue that we need a lot more activism to make some of these things happen. HIV has been a major global success. We now have HIV therapy available to millions in both wealthy and resource-limited countries. And this is really because the HIV lobby has been extremely effective at pushing governments and pushing payers to figure out ways to bring these prices down. When they talked about the initial prices, it was always said they could not make them cheaper. They figured out how to make them cheaper, and they are now very, very inexpensive in most of the world. So this achieved the PEPFAR, the PEPFAR program in the US, which is the President's support for HIV and AIDS research around the world. It's provided more HIV and AIDS research than any other single effort. The Ryan White Law, which means that in the United States, anyone with this infection gets guaranteed federally funded access to HIV treatment. That's not true for any other disease in the US. And of course, the Bill and Melinda Gates Foundation, which has been the most philanthropic organization to give money to medical research ever developed, but none of these three things focus on anything except, well, they don't focus on hepatitis C at all. I would also mention that it is important that industry does have a major role to play here by both bringing down the prices and making them more accessible to people in resource-limited places. We are learning. We are now starting to see more activism coming from grassroots groups, and I would encourage some of the people in this room to be leading some of those charges because they really do make a difference. And the last thing I'm going to mention, just because I mentioned it in the idea about eradication, is will treatment be enough? And the answer is I don't think so. We're probably going to need a vaccine if we really want to think about eradication, but treatment might lead to elimination. So we might be able to contain or get rid of hepatitis C in Canada. I think to get rid of it globally, we'll need a vaccine. I'm not really going to talk too much about it except to say that it's very difficult. But what we can do in Canada is we can think about starting to improve access to groups who have high risk of transmitting the infection. I've talked about people who have high risk of dying of the infection and treating treating those people. But if we actually treat people who have high risk of transmitting the infection, who may or may not have any liver disease at that point themselves, we can prevent new infections. So this idea of treatment as prevention has been very effective in HIV, where you treat people at high risk of spreading the infection, and it lowers their risk of spreading it. And if we look at this in the HCV model, if you started to treat people who are actively injecting drugs or people who are incarcerated and have a high risk of hepatitis C infection, what you can see in this graph here is if you look in the blue bars, just focus on those. If we treat just 40 in 1,000, so that's 4% of people who are using drugs who have hepatitis C infection, we can have a major reduction. In the y-axis is the reduction in the prevalence, so the total number of cases per population in the population if we do that. But that's going to take a huge change in paradigm shift, because right now we've focused only on treating people with active advanced liver disease rather than treating people who have mild liver disease but maybe at risk of spreading the infection. And that is very effective if you have a relatively slow rate of transmission. So effective treatment, if you use this treatment as prevention paradigm and you have a relatively slow rate of new infections, you actually could stem the tide of infection. In developing countries where the incidence, so number of new infected cases, is still very high, we probably do need a vaccine to get rid of hepatitis C. So in developing countries, transmission is largely still through medical exposures. I would argue in some ways this is good news because it's a financial issue. It's really much easier to buy clean needles. Doctors don't want to use infected material. They just don't have access to better needles. And this is arguably something that could be changed and easier to change than behavior. And of course, it has added benefits beyond hepatitis C. So the vision in wealthy nations that we should really have broad access to these very good new agents for everybody. We need to have active case-finding efforts. We need to move treatment into primary care and ideally prevent development of end-stage liver disease, prevent liver-related mortality by treating people who already have advanced liver disease, and then really move into this treatment as prevention paradigm, which I think I would argue in our country is better than a vaccine and more realistic. In resource-limited regions, initially probably access has to be limited to people who have more advanced disease, but fortunately that's still effective, and we really need to focus, and I never hear people talk about it, is focusing on reducing medical transmission, accessing clean needles. So some of that money that's being spent on the drugs should be spent on improving healthcare infrastructure in developing countries so that the spread of not only hepatitis C but other bloodborne infections is reduced. Ultimately, eradication will likely require a vaccine. So the messages I want to leave you with: hepatitis C really is curable. Cure really does save lives. Treatment is improving incredibly quickly, and the challenges of accessing that treatment do differ between high and low and middle income countries. So many of the populations that you're dealing with in the immigrant health population may have different challenges in their countries of origin than they have here. And to finally leave you with the message that although eradication is something we can aim for, it's going to require a lot more than just good drugs. We have to increase our diagnosis rates, including screening, particularly, and I would make the case that in Canada, particularly among the immigrant population, we need to improve access to care both in developed and developing nations. We need to reduce transmission through targeting harm reduction programs to reduce injection drug use and treating those who are actively using, reduce medical transmission, and ultimately we're going to need a vaccine if we're actually going to eradicate this globally. Thank you very much.
My name's Jan Hatcher-Roberts, and I work as a technical advisor for CSIH, and also on the board of Public Health Ontario. So I'm familiar with all the great work. It seems to me that there's the issue of entry and referral, which speaks to family medicine, primary care practitioners, which speaks to primary care guidelines. And there is the Canadian Initiative for Refugee Migrant Health Guidelines, but nothing yet for HCV. So that might help family physicians so that they're aware of the need to refer. I have two questions. One is the cost-effectiveness pill, potential years of life loss, has that been looked at against the cost of treatment, which may help us argue that even though the cost is high, the potential years of life loss and the Halleys and Dallies or whatever else we're going to do will show that it actually is worth it, because at this point you just see the amount of the money. And the other question is a bit more complicated, is that we're separating out refugees and migrants. Now, refugees aren't screened for HCV, but migrants usually are economic migrants, which means they have to have a fairly high level of income in order to qualify. Has there been anything that looks at their and then they say, oh, well, healthcare in Pakistan or whatever is terrible and needles aren't clean, but the people that are coming, they're wealthier, is there a wealth gradient in terms of the risk exposure in the country where it's got a high prevalence? And therefore, what's the decision making, the evidence for saying, well, we need to target this group here just because the prevalence is high? How is evidence-based is that?
Okay, so good question. So the first comment is about the cost effectiveness. So there have been some studies looking at cost effectiveness, and just for those who are not as familiar with that terminology, that's basically looking at the bang for the buck. So how much value you get for your money when you take into account the long-term outcomes of the disease. So you compare it to existing treatments or to no treatment at all. And these treatments, even at these ridiculously high prices, at least with the first models that have been done, look to be cost effective with somewhere in the order, depending on the study, but somewhere in the order of 25 to 40,000 dollars per quality adjusted life year. So just to put that into context, we usually use a benchmark of saying that if something costs less than $50,000 per quality adjusted life year, that it's worth society's willing to pay that. That's fine, but the one challenge for hepatitis C that makes it a little bit different than many other diseases is that theoretically we could treat everybody now, and if we had the infrastructure to do it. And the budget impact of that is enormous. So even though this will have you will save downstream costs in terms of liver cancer, end-stage liver disease, liver transplants, you don't accrue those savings for a long time, and even with the current prices, treating people, even taking into account those long-term things, it is not cost-saving. It is cost-effective. We get good value for money, but the cheapest strategy, if you're just looking at money, would be to treat nobody. Because it's actually, if the prices came down, there is no question with this high efficacy of treatment, we could bring down the price to a low enough value that it actually would be cost-saving, which is very rare in medicine. But because they're so highly effective and this disease has such a great burden of illness, it actually is possible. It just takes reducing the price. Now, the second question that you had was, I was actually looking for Dr. Greenaway, who's right there, who is probably better able to answer that question because she's done some work on this, but is looking at the idea of what is the prevalence in countries versus the prevalence of those migrant populations after they move. And the truth is there are very poor data, I would say. Most of the studies that have looked at this have not done it very well. It's not that easy to do it. So if I wanted to say in the Toronto population, can I identify all Pakistani immigrants to Toronto and check you for hepatitis C and then compare that to the published prevalence in Pakistan, first of all, I have to trust the published prevalence in Pakistan. Second of all, I have to get buy-in from the community here and get broad representation of both communities and trust my samples. And I would say right now the data that have been published are not very good. Some have shown higher prevalence among migrants, and the reason is that we assume that having lower socioeconomic status puts you at higher risk of these infections. When the main route of transmission is medical care, sometimes that actually puts you at higher risk of infection, because in many poor countries, even in high income clinics, there is still reuse of medical equipment. So it could be either way, and that's why I think we need to do the studies, and I think Dr. Greenaway is probably going to talk about that a little bit more, so I'll leave that to her.
Yeah, this is Michael Tang from Vancouver. You identified the challenges in front of us, surveillance and screening. Do you have any package or any materials that developed by your organization that could help us as a layman to bring those to bring the message into action or do it in the field?
So
Thank you.
I don't personally, but I will say that the Canadian Liver Foundation, as well as a number of other groups, have developed some very good patient education and lay education products. Katie has done some nice work. I'm sure there's some representatives from Katie here. There we go. Yeah, they've done some excellent, they've put together some nice resources. I would recommend you talk to them and look elsewhere. I don't have any myself, but there are plenty that are around. The World Hepatitis Alliance also has some very nice literature, which is helpful.
Hi, thank you very much. It's a great talk. Chris Greenaway from Montreal. Just want to follow up on the whole cost effectiveness issue, because I did see your recent paper, and I believe the seroprevalence that you found that it was cost effective and really, you know, at below what the usual willingness to pay is of less than $50,000 was the seroprevalence of 0.5%. And I saw that on your slide there, you picked countries that had prevalences probably of greater than 5%, most of those countries. And so when I think about, and I'll present some of the data that we've collected and some of the other data when I go in through my talk, but just assuming that most migrant populations have a seroprevalence of greater than 0.5%, and the exception may be the Latin American countries, which is maybe why the US is not so keen to screen, because that's more than 50% of their migrants. Mm-hmm. But so assuming that it's cost effective to screen at 0.5%, then what do you think about more broader screening of migrants? Because then that actually includes everybody. Right. If we extrapolate from the global prevalence, which has its issues, but even in the data that's out there, I think that most populations are more than 0.5%. Mm-hmm. So just your thoughts on that, since this is maybe our second largest group in Canada who I think are affected by Hep C. Right.
Now, I have been a strong advocate for trying to get that. So it was relatively recently that the Public Health Agency of Canada included birth in an endemic country as part of the risk factor-based screening, and I work on the ASLD IDSA guidelines in the U.S. to develop the guidelines for hepatitis C treatment and access to care in the U.S. And I can tell you it's been a big fight on that committee to try to get them to advocate for screening immigrants, and you're right that it is largely to do with the Latin American population. The other thing that they argue, which there is some truth to, is that if you follow the birth cohort screening and you include people who are not born here in the birth cohort screening, you still identify the vast majority of immigrants with the infection, because most people that immigrate are actually in the birth cohort, and very few will develop advanced liver disease before they enter the ages if you shift the age. So I would agree that it is a good idea to start screening. The arguments that people have that have made against it are that it's harder to operationalize because you don't always know the country of origin. Ethnicity and country of origin are obviously not always the same. That we don't have great data on what the prevalence is among migrant populations, which I sort of would agree with you, it's got to be above 0.5%, so it's still likely cost effective. And that there has been some pushback among migrant communities about being targeted for screening for anything. So we did some work a number of years ago looking at hepatitis B screening, showed it's highly cost effective to screen Asian-born Canadians, and the Asian community in Canada was not very happy about being screened, with concerns that it would lead to limitations on access to the country, which of course was not the intention, but I could understand why someone might have concerns about that. So I think there may be strategies to operationalize it that avoid specifically targeting populations. That being said, I would strongly advocate that we should be screening people as they move to the country. Thanks. Last question, maybe? Yeah, okay, sure. Sorry, I went a bit over time.
Hi, my name is Raj. I'm from the Committee for Accessible AIDS Treatment here in Toronto. So I'm just going to pick on terminology or language being used, and I think language is very important because using the right terminology has an effect on a person's psyche as well as, and it reduces stigma as well as adherence and behavior. So it does play a big part. Yep. So one of the terminology, and I'm going to make a comparison between HCV and HIV. Many of the things that you presented today, I find a lot of similarities with HIV in terms of suppressing viral load, and proper adherence can prevent full-blown AIDS and people live normal lives, etc., etc. So the terminology you're using is HCV is curable, which is really great because, as I said, it affects psyche. What's the difference? Because in HIV, we say undetectable, which is a suppressed viral load, which is similar to what you just explained. So why the difference in terminology?
So it's a good question, and it's a fundamental difference. So I really do want to stress the point that it's actually a very different thing. So suppressing the virus to undetectable levels with HIV means that while the person's taking the medication, the virus is suppressed, it can't replicate. As soon as that person stops their highly active retroviral therapy, the virus comes back. There has yet to be a single individual, with the exception of one child in the US, but a single individual with chronic HIV infection who ever was able to stop infection and not have the virus come back to detectable levels. People who have the virus suppressed with hepatitis C and go through a successful course of therapy are cured. So they stop the treatment after 3 months. The virus never comes back. So they truly are cured of the infection. Do you see the difference? Now, importantly, they can actually be reinfected. So if they're re-exposed, so if someone who uses drugs goes back to using drugs and shares needles again, they actually can be reinfected. But it's truly separate. Did anyone else have any confusion about that? Because it's a critical distinction. Is one's curable, one's controllable.